I'm going to show you a study done a long time ago, published in JAMA in 2000, and this is a group of American hospitals, and what they were trying to do in this study was demonstrate that care in a university hospital for acute MI was more reliably delivered than in a minor teaching hospital or a non-teaching hospital. And so they are giving it of aspirin, ACE inhibitors, beta blockers, and appropriate reperfusion. And so yes, they discovered that in the major teaching or university hospital, there was a higher degree of reliability with the first three things and no particular difference in the reperfusion, but sort of quite remarkably low results with the reperfusion. So yes, they proved their point, but there's still some pretty big deficits there, remarkable deficits in fact. Now, there's an organisation in the United States called Intermountain Healthcare where a guy called Brent James had spent a lot of time doing exactly the stuff, looking at systems, trying to eliminate variation and developing clinical protocols to overcome that issue of the errors of omission to try and make healthcare delivery more reliable. And they did the same study in their cohort of patients, and what they discovered, superimposing their results here, is that in their systems, the appropriate care delivery was between 90 to 96 or 94 to 96%, much more reliable than in those other hospitals. So that's a remarkably different and better result. So in essence, what we have tried to do is emulate the Intermountain Healthcare product, the blue. To demonstrate that in our system there is clinical variation, cardiology did a study, 12 months of data, 2011, and they looked at all the cardiology type presentations, divided them into three groups: acute coronary syndrome, the ischemia, heart failure, and arrhythmia. And the patients were randomly admitted, they'd come into hospital, go through the ED and admitted under the cardiologist on duty for the evening. And then they looked at what happened according to the subspecialty interest of the cardiologist, whether the cardiologist was an interventionalist, in other words, did the angios, whether the cardiologist was a heart failure doctor, or whether they were electrophysiologist, in other words, looked after arrhythmia. And what they found is, so the one on the left is acute coronary syndrome care according to whether they were admitted under an interventionalist or a non-interventionalist. Similarly, the next one, heart failure care, a heart failure specialist, a non-heart failure specialist, and arrhythmia, or atrial fibrillation in this case, an electrophysiologist or a non-electrophysiologist. And in the red are highlighted some of the differences in outcome. So the length of stay, 3.19 versus 5.52. But look at the 30-day mortality, 1.14 versus 3.69. That's sort of a threefold difference, which is quite something in a group of 1,300 odd patients. And then you look at heart failure, the 30-day readmission rate, but look at the 30-day death rate, 1.52 versus 10.38, an extraordinary difference. And in the other one, the 30-day readmission rate, 14% versus 26%. So really quite significant differences, demonstrating significant variation in practice according to subspecialty interest. So the question then becomes, how do you actually flatten this out? Because what they thought was it didn't matter which cardiologist, which a patient was admitted under, they would get the same care. Clearly not true. Fairly confronting one way or another. Now this is not a straightforward study to do, and I must recognise Derek Chu, who shared these results with me and has allowed me to present them. I think it's a really a sort of a bit of a landmark thing within the organisation. Now what they did was then attempt to stream the patients to come under the right doctors.